Okay, hi everybody. I just wanted to continue a little bit into Unit 10, and that is the cardiac implantable electronic devices. And in these couple slides, I just wanted to talk and summarize the reading, one of the readings for the unit, which is the Canadian Cardiovascular Society guidelines on cardiac resynchronization therapy. I know you're all stressing, so I thought I'd go through a few highlights of the article just to have you know. So the idea behind some of this stuff was having like all these readings in the course is that you understand that there are some stakeholders out there in the world that you can access guidelines, and these organizations set forth guidelines and practice standards, and to get you familiar with some of these the cardiovascular or some of the organizations that will impact you as you start to take care of cardiac patients. And you may see cardiac resynchronization therapy in some of your patients. I know I did, even just on the medicine floor. You'd have some of them come in now with another, admitted to the hospital with another issue, but then on telemetry and noting that, hey, this looks a little bit different than what I'm used to. I'm seeing some spikes, but I don't really understand what I'm seeing here. So then it begs you to kind of understand, okay, what's going on with this patient? And lo and behold, they have biventricular pacing because they have some heart failure, and so they have an electronic device implanted for resynchronization therapy. Okay, so let's get into it. So the New York Heart Association has a classification, functional classification for heart failure symptoms. You can Google these, you can find them everywhere. And just want to briefly give you the classes, and they're mild. They're class 1, 2, 3, and 4. And you can read here, patients with cardiac disease, but without resulting limitations of physical activity. So this is a class 1 New York Heart Association functional class 1. So these people do have heart disease without resulting limitations in physical activity. So ordinary physical activity does not cause undue fatigue, palpitations, dyspnea, or anginal pain. So they do have a diagnosis of heart failure, but they're coping. Okay, so the class 2 is also mild. These are patients with cardiac disease resulting in slight limitation of physical activity. So they're comfortable at rest, and ordinary physical activity results in fatigue, palpitations, and dyspnea or anginal pain. So the key here is that there's slight limitation, and that's the difference between class 1 and class 2. And then the ordinary activity, so nothing terribly strenuous. These are not elite athletes, just regular physical activity, walking a little bit faster because you don't want to miss the bus, would cause fatigue, palpitations, dyspnea, or anginal pain. Class 3 are patients with cardiac disease resulting in marked limitation of physical activity, They're comfortable at rest, but with less than ordinary activity. They're fatigued, they have palpitations or dyspnea, or some or all of these symptoms, or anginal pain. And then you have a class 4, which is severe. So these patients have cardiac disease resulting in an inability to carry out any physical activity without discomfort. Symptoms of heart failure or the anginal syndrome may be present even at rest. If any physical activity is undertaken, discomfort is increased. Okay, so class 1, 2, 3, and 4. So in terms of the Canadian Cardiovascular Society, the statement that you have in the unit, it talks about CRT considerations. So before we think about therapy, what should be in place? So patients should be on optimal medical therapy before considering CRT. Optimal medical therapy includes ACE inhibitors or ARBs, beta blockers, and a diuretic. Okay, so this all needs to be in place before we're considering CRT. So, this is in place and they're still having trouble, then we're starting to think about CRT as a treatment option. Here's the New York Heart Association class. So on optimal medical therapy, and they're a class 2, a class 3, no, sorry for the typo, or a class 4, but a class 4 who's ambulatory. Okay. And this is who, or the patient picture of who CRT is recommended for. So left ventricular ejection fraction, or LVEF, is less than or equal to 35%. Remember when we were talking about cardiac output, and we're talking about stroke volume being the volume of blood ejected from the heart on any given beat. Okay, so we measure LVEF, or left ventricular ejection fraction, with an echo. Okay, and so you can measure the amount of cardiac output or stroke volume. And so we're looking for patients who have LVEF that's less than or equal to 35%. Okay, and so they have to have this, and they have to have a prolonged QRS duration greater than and equal to 130 milliseconds. Don't let this throw you off. We looked at QRS durations in CORN 1, okay, and we looked at everything being 0.10 seconds or less. That translated into, if you remember, the small squares, right? So we measure in seconds for this course and all the testing that you've done and all the activities and questions in the back of the book. But if we just simply convert milliseconds, so seconds to milliseconds, we're just going to slide the decimal over, okay? And that will equal, so less than 0.10 seconds is a normal QRS. That means when we're talking in milliseconds, that would be a normal QRS would be less than 100 milliseconds, okay? And that means for CRT therapy, you would consider only QRS complexes that are, now I've gone and translated it into the number of small squares because that's what you guys have been practicing for all of CORN 1, like 3 1/4 small squares or more, okay? So I'll go back up here. To recommend cardiac resynchronization therapy for heart failure patients, the heart failure patient needs to have less than or equal to 35% ejection fraction. They need to have a prolonged QRS duration that's greater than and equal to 130 milliseconds. And that needs to be due to a left bundle branch block. Don't get fussed. You would learn about left and right bundle branch blocks when you are in CORN 511. So you need a 12-lead ECG to distinguish between a left and a right bundle branch block, okay? But we did look at bundle branch blocks when we looked at, I think, in the ventricular chapters, right? So you are in sinus rhythm and you'll have a P wave, and then you'll have a prolonged QRS complex, okay? So when you look at bundle branch blocks, they start at the SA node, okay? And the impulse comes down through the AV node, delayed there. But when you have a bundle branch block, the impulse starts to come out of the bundle of His, and then when it separates into the left and right bundle, one of them, or sometimes both of them, are blocked. So the stimulus goes down and it'll depolarize one side of the ventricle, so either the left or right ventricle. And because there's a block in the opposite bundle branch, the propagation of the impulse has to go across slowly the septum, and then eventually both ventricles depolarize, okay? So this is a long QRS duration due to a left bundle branch and the person's in sinus rhythm, okay? So that is the key person. That is the one patient presentation that CRT is recommended for by the guidelines of the Canadian Cardiovascular Society. They have another group of people that CRT may be, so it's less of a strong argument, basically, for doing cardiac resynchronization therapy. So with these clients or these patients, the left ventricular ejection fraction, LVEF, is less than and equal to 35%, okay? And you have to have one of these. So a prolonged QRS duration of 150 milliseconds. So that was longer than the previous, but it's not due to left bundle branch, okay? So yes, we have a long duration, but we can't diagnose it being related to left bundle branch block. So there's aberrancy or a weird conduction through the ventricle, and it's not specifically related to left bundle branch, so something other than, and they're in sinus rhythm. Okay, so less than or equal 35% ejection fraction, 150 milliseconds, but not related to left bundle branch block and in sinus rhythm. Or you could have patients that have the left ventricular ejection fraction of less than and equal to 35%, and they have chronic right ventricular pacing or likely to be chronically paced with heart failure symptoms. So, we can have a pacemaker in a patient and we're pacing them, but pacemaker therapy itself, that's why I said one of the key ideas is that we're always trying to promote intrinsic activity, as much of the person's own intrinsic activity, because essentially, as we pace, every time we deliver a stimulus, we're pushing that person, millimeter by millimeter towards kind of heart failure, because we're forcing at a set kind of predetermined rate. So it's not the heart's own natural course of action in terms of the rate at which we're pacing. We determine that. Okay, so there is risk of increasing or causing some heart failure when you're pacing a patient. That's part of, when you're choosing a therapy, that's part of measuring the risk benefit. Because you can't really leave somebody with a heart rate of 30, no, or if they have a full block, you have to put a pacemaker in there because otherwise they'll have syncope, they'll pass out and they're driving and they'll hurt themselves or somebody else. So, it's a bit of measuring the risk benefit when you're selecting therapy, as all of the clinical decision making that we do. Okay. And then here's another group of patients. So this is a left ventricular ejection fraction worsening heart failure. So LVEF is less than, a little bit better than the 35, less than or equal to 45%, and chronic right ventricular pacing, or likely to be chronically paced with heart failure patients. So this slide and the previous, remember, these are groups of patients that CRT may be considered, okay? They're not as strong an argument as the first slide, if I go back to, where CRT is recommended for. All right. When we put the device in, okay, all devices and technology have some options. So with the technology, there's the regular CRT with pacing ability, which is what we want. So we have a lead in the right ventricle, and then we have a lead that goes out through the coronary sinus and it wraps around whatever vessel that where they can get into, vein I'm talking about when I talk about vessel, wraps around the left ventricle and the lead sits there. And so we have a lead in the left ventricle and a lead in the right ventricle. And we're hoping to fire those two at the same time so that the ventricles contract at the same time instead of having, the right depolarize ahead of the left or vice versa, okay? So that's the resynchronization. We're trying to sync the left and the right ventricles to contract at the same time because that's what normally happens in a normal heart without pathology. Okay. The other electronic device that could come in with CRT is a device that has the ability to defibrillate, okay? And so that's what the D stands for. So those are the two types that you might see. And if a patient is suitable for resynchronization therapy, but not ICD, then you put CRT-P, you put a device that's capable, that functionality into the patient. If the patient is suitable for resynchronization therapy and is also suitable for ICD, then you implant the device that has the ability to defibrillate. Additionally, the guidelines talk a little bit about meeting the goals of therapy, which are established between a team or the pacemaker team or the cardiac team, and also the client or the patient. And so, that's one of the big choices too, when you talk about defibrillation is, do you want to be shocked? Some clients may choose that they don't want to because it can be the burden of excess shocks can be a great burden to bear for someone. So all this kind of stuff is, presented to a client when we're talking about therapy, and some of those decisions have to be made. Okay. Okay. This is just talking a little bit about opportunity. So if there is a prior cardiac implantable electronic device in the patient already, and there's some sort of planned revision because they've had it for a while and something's going on and something needs to be done. So whether that's for replacing a lead, looking at the pulse generator, replacing the pulse generator, or there's some sort of infection and you have to go in, this is when, you know, let's look at the patient, because we're going in anyways, let's look at the patient and see what's going on with their left ventricular function, what percentage of right ventricular pacing is going on, what is the patient experiencing, are they experiencing any heart failure symptoms, or is it worsening? And then maybe we can consider CRT, because we're going in anyways. Shall we put another lead into the left ventricle, and if we're changing the pulse generator? Okay, or sorry, if ECG indicates a QRS duration that's greater than or equal to 130 milliseconds as before, and on echo you're seeing a left ventricular ejection fraction of less than or equal to 35%, then we'll also consider CRT. But again, this is opportunity. This is someone who already has an electronic device, a cardiac electronic device implanted, and we're going in anyways because there's some sort of need and plan for a revision. And that's when you'll take a good look at the patient and see whether or not there's any heart failure going on that's symptomatic enough, and are they declining, or are they declining that they would benefit from CRT. And finally, we want to talk about the goals of therapy for CRT, and that's that you are going to have greater than or equal to 95% biventricular pacing, because, and it's high, right? Because you want the ventricles, when they contract or depolarize and then contract, you want them to be in unison. So you're looking at a high percentage of biventricular pacing is what the goal is. You also want to see an improvement in functional capacity. And remember when we talked about the New York Heart Association functional classifications. So you're looking for the patient's own functional capacity to improve in 3 to 12 months time. Seems like a long time, but these clients are all followed kind of regularly in pacemaker clinic or cardiac electronic device clinic, however you want to call it, and just monitoring them. So 3 to 12 months, you're looking for some sort of, and that's the idea, right? And then finally, that there's actually an improved echocardiogram. So I do actually see an improvement in my left ventricular ejection fraction in 6 to 12 months. Okay, so those are some of the goals of therapy. Okay, so the other thing that I would like to impress upon you is that you understand some of the goals and some of the guidelines around cardiac resynchronization therapy, because you're going to see some of those patients potentially in your clinical setting. I'm not looking for you guys to memorize the details of these slides. I want you to kind of sit back and tell yourself it makes sense, right? So if I got some classifications, obviously worsening symptoms, obviously the classes go 1, 2, 3, 4, where 4 is the worst. So if someone's got a class, is a class 3, they're worse in symptoms than a class 1. And then when you look at the concept of left ventricular ejection fraction, that's something that we can see on echo. We talk about percentages of blood that's ejected from the ventricle, from the left ventricle, and that's an indication of heart failure. And when we get down like 45%, 35%, 30% ejection fraction, this is bad, okay? And that's when we need to intervene, because it's just poor cardiac output, and they're going to be symptomatic. And then you look at some of the ECG criteria for CRT that we're looking for, prolonged QRS duration, and that it's related to like bundle branch block and the patient's in sinus rhythm. So I just want this to start like making sense to you, some of the terms and some of the rhetoric around CRT therapy, and kind of understand where do the leads go, and then what is the goal of therapy. Okay, so I hope this helps. And I will post the slides. Thanks, guys.